Once Okay, welcome, madam. Welcome, doctors. Good evening, everyone. A warm welcome to all of you who have joined us today for this important and insightful webinar organized by the AMR Declaration Trust under the guidance of our Managing Trustee, Dr. Abdul Ghafoor, Senior Consultant in Infectious Diseases. The AMR Declaration Trust is a public charitable organization founded on the principles of Chennai Declaration Document and Initiative. Our primary mission is to stimulate discussion, inspire action, and explore innovative solutions to address the global challenges of antimicrobial resistance. We'd also like to extend our heartfelt thanks to our sponsors, Viatris and Pfizer, for their continued support in enabling us to conduct these educational sessions free of cost for all the participants. So today's webinar focuses on highly important topic, role of therapeutic drug monitoring in TB therapy. So here we are delighted to have with us Dr. Priti Bala, consultant microbiologist and infection preventionist at Kaveri Hospital, Bangalore, who will be moderating today's session. Welcome, madam. Dr. Priti Bala brings with her intensive experience in clinical microbiology and infection control, having served as a consultant microbiologist and infection control officer at leading institutions including Sakra World Hospital, Motherhood Hospitals, Ampath Labs, Manipal Hospital, and Apollo Diagnostics. She has also contributed academically as assistant professor of microbiology at the Oxford Medical College and Research Institute. Her expertise is reinforced by advanced certifications in infection diseases at Jupiter Hospital, critical care infectious diseases ISCCM, and clinical virology in NIMHANS Bangalore. She has been instrumental in strengthening infection prevention practices and antimicrobial stewardship program across major healthcare settings, making her a respected leader in the field of infection control and clinical microbiology. We are also very pleased to introduce our speaker for today, Dr. Shruti Vasantaya, MD in microbiology, currently working as a physician scientist at the Institute of Bioinformatics, Bangalore. We are truly honored to have with us today to share her valuable insights on this significant topic. Before we begin, a quick note for all of the participants. Questions are most welcome throughout the session. You may post them in the chat box and we'll be addressing them during the question and answer segment at the end of the session. With that, now I hand over the session to the moderator, Dr. Priti Bala, to take it forward.
Good evening, everyone. Am I audible?
Yes, ma'am.
Yeah. Thank you, Afrin, for that kind introduction.
Thank
So,
you.
it's my pleasure to introduce our speaker for today's webinar and a dear friend, Dr. Shruti. She is currently working as a physician scientist at the Institute of Bioinformatics, Bangalore. She completed her MD in microbiology from the prestigious Jipmer Institute, Pondicherry. Her current research focuses on tuberculosis drug resistance, pharmacogenomics, and precision diagnostics. She is currently co-investigator of an ICMR-funded project developing a nanopore-based sequencing platform for culture-free detection of drug resistance in MTB. She has authored several peer-reviewed publications, including culture-free whole genome sequencing of MTB using ligand-mediated bead enrichment. Her work bridges clinical microbiology with genomic technology development. She has received several academic awards and is an active reviewer of several national and international journals. So over to you, Dr. Shruti.
Thank you so much, Dr. Preeti, for the kind introduction. And I can start the session now.
Yes, ma'am.
Yeah, okay, I'll share my screen. Okay, it's visible?
Yes, doctor, it's visible.
Yeah. Okay. Good evening, everybody. I know it's a weekend, so I'll keep my discussion as engaging as possible. So today, I'm a physician scientist trainee at Institute of Bioinformatics. I'm currently pursuing my PhD in pharmacogenomics of anti-TB drugs, which is a prequel for this particular, this topic is a prequel for that particular topic. So I'll be talking about role of therapeutic drug monitoring in optimizing TB treatment. So I'll be covering the topic under few brief headings. So I'll be covering the topic under these headings. Introduction, I'll explain about what is the actual problem and what is happening, what is interindividual pharmacokinetic variability, and the factors affecting this, and how to measure this interindividual pharmacokinetic variability, and what are the indications for doing TDM, and what is the evidence available right now on the TDM, both for first line and the second line anti TB drugs, and the infrastructure which is needed for doing TDM, and the hurdles to implement this in standard of care, and what are the alternatives for TDM for the setup where you cannot perform TDM due to the cost of the equipments. So, particularly, I'll be explaining about pharmacogenomics uh, for very briefly. So, coming to introduction, as we already know, TB still remains as one of the leading causes of death due to infectious disease. According to the recent global TB report of WHO Global TB report of 2024, globally there were 10.8 million cases of TB reported, and around 1.25 million of deaths were reported. India still contributes to world's highest incidence of TB, representing about around 27% of the global burden. Among the TB cases, drug sensitive TB still accounts for 97% of case burden in India, with a treatment success rate between 85 to 87%. The remaining 3.7% of cases they go for relapse, and around 1.9% had treatment failure. So, as we know, there are TB treatment is always being given as multi-drug therapy. In drug-sensitive TB, we give isoniazid, rifampicin, pyrazinamide, and ethambutol for the treatment. Still, in India, we are using ethambutol in the continuation phase, whereas WHO doesn't recommend for continuation phase. I'll talk about that, why that specific ethambutol is important, why I'm stressing on that in the further slides. So these anti-TB drugs are given as fixed dose combination based on the standardized weight-based weight band of the patient. As you can see from the table, different weight band of the patient will be receiving different number of tablets, which will be given as a FDC. That means it's a fixed dose combination, which will be having all the four drugs in a single tablet to reduce the pill burden. And this FDC and standardized weight-based dosing started way back in 2010. So after that, whatever findings on ADR and TDM are there, they are more relevant for us to study even now, rather than taking the old papers which might have mentioned more ADRs when the drugs were not given based on the standardized weight band. But did it solve all the problem, the standardized weight-based dosing? No, it didn't. In spite of giving this, patients still presented with variable plasma drug levels. So what is this variable plasma drug level which I'm talking? It is nothing but interindividual plasma drug variability, which is caused due to giving standardized weight-based dosing. So what happens when you give this? Not every individual metabolizes the drug same. So every individual metabolizes the drug differently. So the patients who are metabolizing the drug very fast, they will be having low drug levels in the blood, and the patient who metabolize the drug very slow, they will be having high drug levels in the blood. So what happens if there is high drug levels in the blood? This causes toxicity or adverse drug reaction. So what happens if you have low drug level? It might be a determinant for treatment failure, slow response, and the emergence of drug resistance. So as I was talking about adverse drug reaction due to slow metabolizers. In these patients, as you can see from the table, these are the adverse drug reactions caused by first line anti TB drugs. Through isoniazid, it is peripheral neuropathy and hepatitis. Rifampicin will be causing varied number of ADRs, as you can see from this table. I'll not explain individual of them. And ethambutol, you can see optic neuropathy. I will specifically say, if you remember from your pharmacology classes, through your medicine classes, so you know, in ADRs, again, you have type A ADRs and type B ADRs, which are caused due to pharmacokinetic variations, are called as type A ADRs, and the one which are caused due to idiosyncratic reactions, we call those are called as type B ADRs. So specifically, when we talk about optic neuropathy, it is most of the time it is type B ADR where the drug concentration in the plasma might not explain it. So, and among the adverse drug reactions caused due to first line anti TB drugs. Drug induced liver injury is the most common adverse drug reaction. Journal of Gastroenterology, they have seen that around 46.4% of the patients taking first line anti TB drugs experience drug induced liver injury in India alone as compared to other population. So why is it happening only in India? The maximum number, why is it happening in India? Why do we have this? I'll explain this when I come to the pharmacogenomics part of the study. So as you can see from this table, these are the adverse drug reactions which are caused due to second line anti TB drugs, which I already explained in the first slide. So, according to the WHO Global TB report, around 97% of the patient, 85% of, sorry, 85% of the patients were going for treatment success rate in case of drug sensitive TB, whereas for drug resistant TB, only around 68% of the patient went for treatment success. The remaining approximately around 32% of the patients they experienced unfavorable outcomes like treatment failure, loss to follow up, or death. So why is it so? Why is it happening so? Most of the time, patient in the Indian scenario, uh, especially when you are treating drug resistant TB, about around 83% of the patients they experience at least one adverse drug reaction, with around 24% of them developing severe reactions which make them stop taking the drugs. So this is as simple as easy as the reason. So as you can see from these side effects, again these side effects can be classified as type A ADRs and type B ADRs, which I'll not be going in detail. So when I talk about adverse drug reactions which are caused due to high plasma drug concentration, there is one more thing which is happening. It is low plasma drug concentration. What is it causing? It is causing adverse treatment outcomes. So, this pharmacokinetic variability in the patient is causing inconsistent plasma concentration. As you can see from the graph, which is plotted with Mycobacterium tuberculosis log concentration along x-axis and the number of patients along the y-axis. As you can see, the fast acetylator, you can ignore the acetylator part. You can just remember for right now as fast metabolizer because it is not acetylation for all the drugs. If uh, in this study, they have found that if the patient is having a fast acetylator phenotype in the body, especially the NAT2 enzyme, they are having low MTB clearance within 3 days, which is shown in the log CFU concentration, and the slow acetylator had slow clearance of this, slow clearance, fast clearance for this decline. So, as you can see from this meta-analysis, they have also reported that fast acetylators have twice the risk of treatment failure and acquired drug resistance, and around 30% of greater risk of relapse after treatment. So, as you can see from this study from China, from Cheng et al., they have also reported that around 20 to 30% of the patients uh, had around within therapeutic range of drug concentration for all the first line anti TB drugs, which is way too less even after giving weight based dosing. And you can see from this meta analysis, which was conducted by Pasipanodia et al., they have shown that rapid acetylators were more likely than the slow acetylators to have microbiological failure and treatment failure even when they were on more than 3 antibiotic drug regimen. So, how do we monitor this, the ADRs or the treatment failure? How do we monitor this interindividual pharmacokinetic variability? So, we might have studied this concept on therapeutic drug monitoring during our medicine classes, but I will briefly touch upon it. So, therapeutic drug monitoring is nothing but a clinical practice of measuring specific drug concentration in a patient's blood at designated intervals so that you can ensure optimal efficacy with minimal toxicity. As you can see from the graph above, which is plotted with time on the x axis and plasma drug concentration on the y axis, we have something called minimal toxic concentration, which is starting from that orange color, that is the minimal toxic concentration, and the blue color will be your minimal efficacy concentration. So in between the minimal efficacy concentration and the minimal toxic concentration, the range which you are finding is therapeutic window. So, why is it important to know what is the therapeutic window of the drug? Lower the therapeutic window or narrower the therapeutic window, therapeutic drug monitoring becomes very important in those patients. So, and there is this concept of steady state concentration. What is it? I'm talking about the steady state concentration. When you start giving the drugs to the patient, if you start measuring the plasma drug concentration at, for example, pre-dose at 0 hour and post-dose at 1 hour, 2 hour, 4 hour, 6 hour, and 8 hour, you might not be getting the same reading if you start taking that concentration measurement every day as soon as you start the treatment. So every drug takes some time to achieve that steady state concentration where the plasma concentration achieved when the rate of drug administration is equal to the rate of elimination. Usually it is achieved after 4 to 5 half lives of the drug, and always it is not the therapeutic drug concentration, the AUC or Cmax will look similar as I've shown in the graph above. It is not always a round, proper, bell-shaped curve. So there are crests and troughs which you see in the measurement when you actually do the TDM assays. So, what are the factors which are responsible for interindividual pharmacokinetic variability? There are physiological factors coming to age and gender and the body weight and pregnancy. When I talk about body weight, when we look for TDM studies or when we do TDM studies or pharmacogenomic related studies, we usually take fat free mass index, where you will be taking the skin fold thickness of the patient and calculating the fat free mass index of the patient. And the physiological factors like hepatic or renal impairment. As we know, most of the drugs are cleared or metabolized through liver, and there is a renal excretion and there is a excretion through liver. So based on the type of the drug where it is getting metabolized, we have to always keep checking liver function test and renal function test for these patients to optimize the drug doses. This we usually do for most of the drugs which have narrow therapeutic index. And other pathological factors like HIV, diabetes, in malnutrition. The patient might be taking the same drug, but might not be absorbing the entire drug as it is happening in most of the patients, especially the patients who are having IBD, celiac diseases, all those patients. And what are the environmental and lifestyle factors coming to the food, whether it is taken with the food, before the food, also plays a huge role in the absorption of drug and the patient to obtain their therapeutic level. Recently, I think few years back, there was a study from Hinduja Hospital on how the rifampicin is getting absorbed and how the concentration, plasma drug concentration is achieved when the tablets were taken with the drug, with the food, and before the food. And other factors like alcohol, smoking, they also can modify the enzyme activity and thus the absorption. The another important factor is drug to drug interactions, especially these TB patients. When we see in the clinic, most of them will be having polypharmacy. So they'll be on other drugs, maybe because for HIV co-infection, maybe they might be having co-infection with hepatitis B. They might be having other diseases like hypercholesterolemia or cardiac diseases. So the most of the patients will be coming with polypharmacy to us. So it becomes very important to know if the patient having polypharmacy, if he is having or taking any drug which are inducers for any CYP enzymes, cytochrome P450 enzymes, or they are inhibitor for any particular cytochrome P450 enzymes. This you can usually check in a drug DB database, where you can easily find out what are the drugs which might interact and how you can see the adjustment of the dose and all. For that, usually we do model induced precision dosing and all. And then the drug related and adherence factors. It is also important to keep the formulation of the drug constant throughout the therapy. In India, it is formalized. Most of the patients are taking through the national program. So most of the patients are having the same kind of drug, which is coming from the same company or the same factory manufactured and all. And also, it is important to have good stability and storage of this drug, which affects the bioavailability. And also, it's a common problem to have a patient with irregular intake or missed dose of the drug. In these patients, also, the concentration will be variable in the plasma. And last but not the least, which is very important factor, is genetic factors. As I already explained, not every patient metabolize the drug in the same way. A person with having a NAT2 genotype, which is a fast, who is a fast acetylator, especially we check it through 7-SNP model or 5-SNP model, be it whichever, which is suitable for that particular country population, which is not blanket panel which you can use across different population, because now after 10,000 genome presentation from DBT India, we know Indian genetic makeup is so different compared to the American genetic makeup or be the UK genetic makeup. So we have to know individuals' genetic makeup to adjust the dose, especially in case of isoniazid, which is also given as a black box labeling by FDA, where a person who is a slow stellator, be very cautious when you're giving the drug to prevent drug-induced hepatotoxicity. So, other than NATO, there are various other variants which are under study. Multiple studies are going on. We are also conducting one of the study in collaboration with Jipmer and Father Muller Medical College. So, what are the routine indications for TDM in anti-TB therapy? So, if there is a, you cannot do TDM in a Indian kind of setup where most of the patients are taking treatment from a primary healthcare setup, where having a ELISA platform itself is a big thing. So, when do you have to refer the patient for TD? So, if there is a suspected subtherapeutic levels, especially in case of poor clinical response or slow culture conversion, and in case of patients with malabsorption, constant diarrhea, and any gastrointestinal disorder. Again, here one question pops up in my mind. If that poor clinical response is might be because of the drug resistance as well. According to our national program, we're only checking for rifampicin resistance when he first walks in. So, first thing what you have to do is follow the standard protocol, get his first line LPA done, and if he's sensitive and still he's not responding, then refer the patient for TDM. And if there is a high risk of toxicity in patients with hepatic or renal impairment, if they are chronic renal failure patient or chronic liver disease patients, and in case of advanced age or in pediatric patients, and as I already mentioned, in patients with polypharmacy, or if there is a potential drug interactions, especially if efavirenz based therapy patient is on, or any of the CYP enzyme inducer therapies. And then the special populations like HIV co-infected patients on ART, pregnant or lactating women, and patients with low body weight or malnutrition. So the dose optimization needs are very important in case of drugs with narrow therapeutic index, which I already mentioned, especially in case of linezolid and amikacin. And it is also routinely done in research or programmatic setup where we have a pharmacogenomic study going on, or we want to develop a POP PK based drug levels for the patients who are currently there. So, population PK, POP PK is okay. So, in those setup, again, we will be doing therapeutic drug monitoring. So, how do we do this therapeutic drug monitoring? So basically, we have to measure plasma drug concentration. Its concentration maximum, concentration minimum, and the area under curve, which we are usually measuring to assess the variability. For this, a full study, if you think about a gold standard for any of the test, you have to usually use a platform which is highly sensitive, highly specific, which can even measure up to picograms of picogram per ml of the drug. So usually the common or the standard instrument we use to measure is LCMSMS. In most of the labs which are performing therapeutic drug monitoring right now, they are using HPLC based testing, which is again useful if the patient is having high drug levels. Definitely, it gets picked up and you can measure it easily. So, but when you are doing therapeutic drug monitoring, ideally they expect you to do like take the blood sample at 0 hour, that is pre-dose, before the patient takes the tablet. Again, supervise in front of you, the patient should take the tablet. After the patient takes tablet, 1 hour, 2 hour, 4 hours, 6 hour, and 8 hour. This is a routine norm which we use for first line anti-TB drugs. And how do we take this time into account based on the T-half of the drug? What is the half-life of the drug? So this is a figure which I've taken from one of the psychiatry drugs, just to explain what are these different models. So don't go by the time which is mentioned there. So what is this naive pool method? Basically, they will be collecting samples from all the patients, putting into a pool, considering it as a single sample and plotting the graph. And they'll see, okay, this is the common PK or the pharmacokinetic range which we usually see in the patients when these drugs are given. But this cannot be used in a clinical setup for patient to measure the drug dose concentration because here we are considering everything as one. And then we have individual nonlinear regression where every individual is taken as a case and the graph is plotted, and they will be seeing how many percentage of patients are going for high drug doses, high drug levels, and how many are going for low drug levels in the plasma. And then we have nonlinear mixed effects modeling, where you can see both the population estimate as well as the individual estimate. So the gold standard whenever we talk about TDM is nonlinear mixed effect modeling. But is it possible to do that in all the patients? No. There are other ways to do or measure inter-individual pharmacokinetic variability. We do population PK modeling, which I was telling, POP PK modeling. It can separate inter and intra-individual drug variability, where basically what we do is for every individual, as you can see from this figure, for every individual we'll be measuring the drug concentration at different time points, and a graph is plotted. We will know how the Cmax and the AUC are seen in most of the population. But is it possible to do this and use this for predicting for your particular patient? No. For that, we use something called Bayesian forecasting, where we will be measuring the individual person's pharmacokinetic value at one time point, which is very feasible when you call the patient in the OPD. One time point testing can be done, and we plot it on the graph where already POP PK is done, and we estimate where this patient might fall, whether he's a fast metabolizer or a slow metabolizer, if he is having high drug concentration or the low drug concentration. So this is how we do. There is now something called as induced precision dosing or model indicated precision dosing, where in the pharmacokinetic model we can also integrate the genotypic values. For example, if he is a fast acetylator. He is having a fast acetylator genotype for NAT2. Again, when we talk about genotype, we look for haplotypes. One haplotype on one strand, he's having a fast acetylator genotype. Another strand, he's having a slow acetylator genotype. And then we combined, he's a normal acetylator. Maybe he's having fast acetylator genotype on both the strands. He is a fast acetylator genotype person. So this acetylator status also can be integrated in the model when we are looking for how we can correct the dose of the patient. Okay, so these are the different ways, but what is the common way followed? It is measuring the drug standard at one particular time point. So how do we choose the time point for the patient? So this is a normal pharmacokinetic parameter of most of the anti-TB drugs. The newer ones are not added here. Um, so as you can see, for most of the first line anti-TB drugs, which are there in the first five columns, first five rows, it is usually 2 to 4 hours, which we say where you can measure the peak concentration or the Cmax of the drug. So, for most of the first line anti TB drugs, we do something called C2H levels, that is concentration at 2 hour levels. But for the second line anti TB drugs, it becomes a little tricky. Individual drugs, you should know what is the Cmax level, at what time point you have to do the testing. Also, when it comes to some drugs like clofazimine and ethambutol, they have a biphasic mode of metabolism. That means one peak you get at 2 to 4 and then at the 12 to 14. So for these continuous monitoring is needed for these drugs. But is it needed to do continuous monitoring for, is it possible to do continuous monitoring for all these drugs in our setup where most of the patients are coming to primary healthcare setup for the drug sensitive TB treatment? It's not possible. There are alternatives, what we can do, which we'll be discussing further. So, as I already told, TDMs is still the most common approach used across the globe to assess the pharmacokinetic variability. And globally, not only in India, globally, TDM has still been practiced mostly in a reactive manner. That means when the patient comes to us with an adverse outcome, be it a drug resistance, be it a slow response, or be it a ADR, adverse drug reaction. Mostly it is followed in a reactive manner rather than proactive manner. Often it is performed only at C2R for most of the drugs, limiting full pharmacokinetic assessment where they are not taking blood at different concentration, because you have to admit the patient if you have to do a full pharmacokinetic study, which is not a possible thing with the high workload in the TB clinics. So the pathogen susceptibility window often does not align with the traditional therapeutic window. Okay, I was talking about plasma concentration. Does that plasma concentration holds good for extrapulmonary TB? The TB is in the brain, it's a TB meningitis. So, measuring plasma concentration, can you tell that this patient will respond better with just measuring plasma concentration? No, most of the cases, there are some studies right now coming up, like in past 3 4 years, many studies have come up on measuring of the drug concentration in CSF fluid and adjusting the dose based on that. Again, that's a far fetched thing when we talk about programmatic and addition of any of the new diagnostic assay. Then polypharmacy, as I already mentioned, it complicates the drug-drug interaction and accurate interpretation levels. In case of patient with polypharmacy, again TDM is suggested. So these are the therapeutic drug monitoring targets for anti-TB drugs and the time duration at which the sampling is done for most of the anti-TB drugs. As I already mentioned, for all the first line anti-TB drug, it is C2H level, which we measure to check if the patient is having high drug levels or if he is having the drug levels in the target. These are the target levels. Why am I telling I have taken it from different studies? Because there is no standardized guideline which tells this is the target level which you have to look for in this particular patient to say he is having within the target level or he's having toxicity. It's usually from various studies which have done RCTs from where the evidence is very robust. We have taken these numbers. That is one of the lacunae which is currently there when it comes to TDM. So, what are the evidences currently available which are supporting TDM? There was a study by Peloquin et al. On MDR-TB adults. Upon giving TDM guided dosage adjustment, there was a 100% treatment success rate in those patients, and there was improved sputum conversion rates. And in case of drug sensitive TB, TDM of isoniazid and rifampicin, there was a 90% target achieved with AUC dose adjustment. And in HIV TB co-infected patients from a study from Alphanar et al., the treatment outcome was I forgot the percentage here. There was around 80% of reduced toxicity, if I'm sure. I can check this and tell. There was around 80% of reduced toxicity and improved treatment adherence. So there is systematic review on TDM in first-line anti-TB drugs. So according to this systematic review, um, they have found that the subtherapeutic plasma concentrations of isoniazid and rifampicin were linked to delayed sputum conversion and higher relapse rate and treatment failure. This is not old study. This is still a new study which is published recently in 2025 June. So we are still there where we are just measuring the plasma concentration. Oh, it was low, and that's the reason why patient went for treatment failure, instead of us publishing a paper telling that we adjusted dose in these many patients and there was treatment success. Yeah, we are still there. So, what are the evidence of TDM in second line anti-TB therapy? The people who are uh, writing enthusiasts, or people who are enthusiasts in writing systematic review and meta-analysis, it will be a good exercise to write one on second line anti-TB drugs, because most of the data what we get is everybody has done for one drug. Nobody has tested for all the drug in the same paper. So I'll be just briefing two, three of such papers where they have looked for they have done tedium for levofloxacin separately, they have done tedium for linezolid separately, they have got wonderful treatment outcomes in terms of high cure rate and high treatment completion rate. When you actually make the patient to take a apparently like ideal amount of drug or the dose of drug, he will not come up with adverse drug reaction. Reactively, he will not stop taking the treatment. That's how you also prevent loss to follow-up rates, which are usually not mentioned in most of the studies. And there's a study on linezolid, as I already mentioned. They had taken around 556 uh, TDM data on linezolid from 330 patients, where around in different age group they could see around 31.6%, 54.8%, and 75% of the patient had supratherapeutic linezolid trough concentration at first stadium assessment, and dose adjustment was needed in approximately 30 to 70% of these patients, which is a huge number, and it's a huge margin again when you talk about different age groups. Then, what are the methods for performing tedium? I'll not be explaining every method in detail, because one method for we have developed a method for all the first line drugs in a single method, which you can do for 13 minutes. You can get all the four drugs, also the metabolites. But the thing is, every method will take 1 hour of discussion when we start discussing. So, here I'll be just briefing about what are the sample types, what are the methods, what are the approaches, or what kind of analysis to be done, and what is the timing of this sampling. So the common sample which I've highlighted in blue, or the common practice which are done across, that is plasma or serum sample, is a gold standard which is taken for measuring the drug concentration. Other than that, there are studies which are showing DBS, especially for patients who are in the rural setup or in the tribal setup where the TB burden is high, or in not reachable areas, mostly in the tribal setup. In those kind of area, if you want to do tedium, transporting or taking the blood from the patient, transporting, maintaining the cold chain. Whenever we do PK study, we usually advise take the blood sample within 30 minutes, separate the plasma, store it in -80, which is not a possible thing in tribal setup, where we usually suggest them to do a dried blood spot. So there are few studies which have mentioned on dried blood spot can be used as alternative sample or alternative matrix we call when we talk about LCMS for easy transport. There are other studies on saliva and urine for non-invasive measurement, which are not currently under practice, which are individual one study on pyrazinamide and one more study on linezolid we have found where they have tested on saliva as well as compared with plasma sample. But the gold standard even now is plasma, which is taken across the labs which are doing tedium. And the analytical method, the common method used in the labs right now is HPLC, which is cheaper equipment as compared to LCMSMS, which is a highly sensitive equipment where you can measure all the four drugs at the same time. And there are other methods like ELISA and UV fluorescence. There are currently no standard ELISA or UV fluorescence based method for testing anti-TB drugs, but these are under development. There are few research articles which you can find where they have done this. And then PK approach, non-compartmental analysis. In a simple word, if I talk about non-compartmental analysis in a layman term, they are taking whole body as one single compartment and they are doing the analysis. So this is non-compartmental analysis. Compartmental analysis means individual liver is a separate compartment. So that compartmental analysis is currently not done for most of the anti-TB drugs. And there are other models which I've already explained, POP, PK modeling, and Bayesian dose optimization. And the timing of sampling, usually it is peak, Cmax, or C minimum, or the AUC. Based on the drugs, this what component has to be tested changes. As I already mentioned, for first line anti-TB drugs, most of the time it is C2H level or Cmax level. And in case of linezolid, what we see is trough levels. So they correlate well with the toxicity risk and they correlate well with the efficacy. So, what are the hurdles for implementation of TDM assay? It is the infrastructure and the laboratory requirements which is needed. We need specialized laboratories which are equipped with LCMS and HPLC or UPLC. One machine costs around 2 crores, which is a huge investment for any of the lab to make. And the limited availability of these equipments in resource limited settings. Also, most of our drug sensitive patients are treated in primary healthcare, if I'm not wrong. They don't come to the tertiary healthcare for treatment. So, also, the cost needed for the equipment and the expertise needed for handling these equipments. So, the cost constraints and skilled personnel which are needed, also multiple time point of sampling which is needed if you want to do a full PK study. Routine TDM for all patient is economically not feasible, as I already mentioned. In globally, even after having a good amount of money in most of the countries, it is still reactive testing which is done, and it requires a trained staff, as I already mentioned. And sample collection challenges, which I mentioned recently in our PK study, we actually, if there is a breakdown of -80 next to the word, we have to keep the sample in dry ice and then transport it to the lab which has a -80. So these are the challenges when we talk about the sample collection and the transport. And if you want to do multiple time point of collection, we have to prick the patient almost around 8 times if you want to do a full PK study for first line anti-TB drugs. Again, it is not possible to convince the patient for collecting multiple time point sampling. And alternative matrices are currently being tested. As I already mentioned, DBS, urine, CSFR are under testing. They are not fully standardized and not used for patient care as of now. And as I already using an internal standard, so how much was lost during sample prep in our lab might not be same as the amount of drug lost due to the sample preparation phase in the another lab. So again, these varied TDM protocols between the center and also the sensitivity of the equipment makes a difference. And these are the hurdles. So are there any point of care methods? When I talk about LCMS, the machine itself is huge, infrastructure needed is huge, cost needed is huge. Are there any point of care methods where you can take it to a tribal setup or just do it? So currently, as I mentioned, DBS assays are there where you collect and then ship it to a place where they are doing it in the LCMS. Or there are volumetric absorptive microsampling. These are not available for anti-TB drugs. Let me clear it. These are available for other drugs, but I have mentioned it here so that if anybody wants to develop or collaborate with someone who is developing such assays, it's a good thing for us. And then fluidic and biosensor based assays where you can get a just take a finger prick blood sample, rapid result you can get within 1 hour. And immunoassay based POC kits, I've seen these immunoassay based POC kits especially for anti-cancer drugs and immunosuppressive drugs, uh, which are currently lacking for anti-TB drugs. These are the tests which can be thought of when we talk about point of care diagnostic assays. Okay, these are two studies which I mentioned already. Saliva based point of care assay, where they wanted to measure the pyrazinamide drug concentration in the saliva. uh, they are around found around plus or minus 10.5% of error for the lower high quality control concentration. And there was one more such study on linezolid, where the saliva to plasma concentration, the average was around 1.018, which is quite good with a p-value of less than 0.01, which might be thought of as an alternative to the blood sample in the patients when we talk about different matrices. So I told about type A ADRs and type B ADRs. So can all the ADRs be answered by the variable drug concentration? No. So not all adverse drug reactions are due to variable drug levels. There are certain adverse drug reactions. Why I was stressing more about ethambutol when I was talking about adverse drug reaction, and how in India, even in the continuation phase, we are still giving ethambutol, though we are having patients. We currently have one of the study planned on ethambutol induced optic neuropathy. Like, the cases are coming up with ethambutol induced optic neuropathy. Still, we are giving the dose for the entire continuation phase when WHO has completely removed it, just because of the fact that India has high monoresistance for isoniazid. Instead, we can think of an approach where we can check for isoniazid as well along with rifampicin, instead of pumping unnecessary antibiotic to the patient. And also, there are other adverse drug reactions. These are called idiosyncratic reactions. In case of rifampicin, the thrombocytopenia, the hemolytic anemia, they are not related to the drug concentration of the patient. And in isoniazid, the lupus-like syndrome is possibly linked to HLA-B25 and CYP2E1 polymorphism. The CYP2E1 is the a thing which comes in the metabolism. If you see the metabolism pathway of isoniazid, the first enzyme which you come across is NAT2, and the second one is CYP2E1, and then GSTM1, GSTT1. These are all the genes which will affect isoniazid metabolism also, along with causing idiosyncratic reaction. And then in case of linezolid, especially lactic acidosis, there is one paper on a mitochondrial gene variant which is responsible or which is implied in causation of lactic acidosis in the patients. So it's not always the drug concentration or doing tedium will fix the thing. Also, doing pharmacogenomic analysis is very important when you want to identify these kind of cases with type B or idiosyncratic reactions. So, is there an alternative for tedium? Yes. So, there is this concept called pharmacogenomics, or personalized TB treatment by precision dosing. So, basically, pharmacogenomics is nothing but optimizing a plasma drug levels by personalized dosing by measuring their genetic makeup. So different individual metabolize the drug differently, as I already mentioned. These mutations which are present in the genes which encode for the proteins needed for absorption, the receptors needed for absorption, and the enzymes needed for metabolism, and the proteins needed for plasma protein binding, or the proteins or the enzymes important in the excretion of the drug. So all these come to play when we talk about pharmacogenomic way of testing. So mutation in these genes may impact not only the metabolism, all the levels of pharmacokinetics of a drug, where tedium only talks about the metabolism of the drug. So, this individual specific genotype can be used for guiding personalized dosing. So, why I was stressing more about pharmacogenomics? As you can see from this image, which is published in Clinical Infectious Disease in 2020, almost half of the population is receiving either too high or too low of the doses. As you can see, the red marking is a rapid acetylator status. The green marking is intermediate acetylator status, that is normal acetylator, and the blue marking is slow acetylator. If you see last but one, that is India, where you can see treatment failure was seen in around 0.12% of patients who were rapid acetylated and toxicity in 0.40, which almost makes around 0.52, which is more than half of our Indian population is getting either too high or too low dose of the drug. It's not only with India, it's also seen across different population with different frequency. So that's the reason why it's important to study the genetic makeup of an individual before we prescribe the drug, which can be easily done when a patient comes to you and gives you a sputum sample. Sputum not only has your MTB, it also has your human DNA with human cells. In the same sample, you can do both human DNA extraction as well as MTB DNA extraction. Do that one test and check for that one particular polymorphism in NAT2, and you can tell him, okay, you are a drug sensitive TB patient, you take this much dose of the drug. So did anybody do that kind of testing? One of the study from my current guide lab, previous lab, they have developed a point of care diagnostic assay with gene expert for checking NAT2 polymorphisms. And are there any studies which talk about the complete treatment success rate by doing pharmacogenomic guided dosing? Yes, one such study was done by Ajuma et al. In Japan in back in 2013. We are in 2025 now. Even after that, nobody is talking about how we can use PGX guided dosing in India. So they enrolled around 172 TB patients randomized in PGX guided isoniazid dosing, and they could observe there was a reduced drug induced hepatotoxicity from 78% to 0% in case of slow acetylators, and reduced treatment non response rate. That is, they checked through 2 month culture positivity or chest radiograph non response rate. It was reduced from 39.5% to 15% in fast acetylator, which is a huge number and which is a very significant number. So now I'll not take much time. We'll discuss two small cases, one for drug sensitive TB, one for drug resistant TB. So this there was a 45-year-old male patient with pulmonary TB. He was on HRZD for 3 weeks. He presented with fatigue, nausea, and mild right upper quadrant pain. So his LFT showed AST level of 165, ALT level of 210, and a bilirubin of 1.2 mg per dl. So he had a mild hepatomegaly on examination. So this table particularly tells about what level is a toxic level. More than 10 is toxic for isoniazid, more than 30 is toxic for rifampicin, more than 8 is toxic for ethambutol. So this patient was sent for TDM analysis. His isoniazid C2H levels were shown as 13.2 microgram per ml, which is supratherapeutic, which is more than 10, obviously. Then rifampicin, which is 12. Again, it is rifampicin is in the normal therapeutic range. Pyrozinamide, it is 28, which is in the normal therapeutic range. So here they interpreted it as elevated INH level, which suggests toxicity. They also checked for pharmacogenomic testing, where they found he was a slow NAT2 acetylator phenotype. So here, the next modality of treatment, how did they manage him? They stopped isoniazid, continued non-hepatotoxic drugs. They repeated LFT after 1 week, reintroduced INH at 150 mg per after LFT normalization, avoid alcohol, and if the patient still persists with the recurrent toxicity, replace INH with other drugs. So the key point in this case is look for the signs where patient comes to you with ADR can't be explained by any other chronic liver disease, renal disease, all those parameters. Get a pharmacogenomic testing done for NAT2 genotyping and adjust the dose for these patients. Then the case two, quickly we'll go through. So there was a 52-year-old female with MDR TB on linezolid and levofloxacin, clofazimine, and cycloserine for 8 weeks. She presented with fatigue, tingling and numbness in feet, and loss of appetite. On examination, they found that patient had pallor, mild neuropathy, and the HB was around 8.4 gram per deciliter. LFT and RFT was normal, so nothing to do with her chronic diseases. So when the TDM was done, linezolid drug concentration was found as 11.2 microgram per ml. As you can see, the toxic threshold is 8 to 10. She's having a supratherapeutic concentration. So it was interpreted as elevated trough level, which is correlating with bone marrow suppression and neuropathy. So the normal renal function suggests that there is reduced non-clearance or pharmacogenetic variation. So this patient, when the pharmacogenomic testing was done, this is that one case which I was talking, which is published. They have found that in the mitochondrial genome, I think it is A270. 276 A to G change. I forgot the proper change actually. So they found that this person is having that particular mitochondrial genetic variability, and they managed it like by withhold the linezolid drug dosing for 1 to 2 weeks. They monitored the HB and symptoms. They restarted it at 300 mg. Initially it was 600 mg, and they repeated the tedium for these drugs where there is no standard guidelines in at what intervals the tedium has to be repeated. Close observation and weekly or every 2 weekly CBC will help us to see if the patient is again going for toxicity or he is having a normal drug concentration in the blood. They also treated the neuropathy by adding pyridoxine. So the key takeaway from this talk is tedium explains the pharmacokinetic ADRs, but pharmacogenomics explains the pharmacogenetic ADRs. And patient management has to be done by integration of both these things, where it will give you a complete view of what is the reason for ADR causation. Is it due to high drug levels or due to a therapeutic range or due to a pharmacogenetic variation? So I would like to thank AMR Declaration Trust for providing me this opportunity to talk on role of TDM. And I would like to thank our team at IOB Infectious Disease team. As you can see from this picture, the person next to me is my guide, my mentor. The person behind her is her mentor. He's not a part of IOB, but I couldn't find one picture where we had all the team members in a similar one. So I had posted this. That is Professor Jason Andrews. And I would like to thank my guide, Dr. Renu Amma. My co-guide, Dr. Akhilesh Pandey, is a faculty at Mayo Clinic, Rochester. And I would like to thank Dr. Preeti Bala Take. I've worked with her for a few of the projects, and we have worked on a few papers. So thank you, Dr. Preeti, for inviting me for this talk. And disclaimer, I have no financial or professional affiliations with anything, and this is purely for academic and educational purposes. I'll be happy to share any of the study materials or any references if anybody needs. You can reach me out at shruti_vasantaya at ibioinformatics.org. Um, thank you for your attention. I'm open for questions now.
You have to unmute, Afreen. You have to unmute yourself.
Thank you, ma'am. Thank you for this insightful session, madam. So, as of now, we have a lot of appreciations and question-wise, I don't look any questions as of now. There's no questions.
So till then,
we have a question.
Sorry to interrupt. Till then, I would like to go ahead with few questions. So my first question, we just want to know about few centers which are performing this TDM essays in India, both government and private sectors.
Yes. When we talk about centers, because Dr. Preeti is in Bangalore, I will tell about Bangalore. I think Anand, not I think, I'm sure, Anand Newberg at Shivaji Nagar, they are performing. Not sure about the address. Anand Newberg is performing TDM for first line anti-TB drugs, all 4 drugs. And apart from that, across India, Hinduja is performing TDM assays. And if you talk about government setup, people can very well send the samples to NERT Chennai. So these are the places which I know about. Other than that, I was just Googling one day to see how much it would cost now. Thyrocare is also giving the test, but individual, isoniazid separate, rifampicin separate. So these are the places which I know about who are doing
And what
TDM.
about the cost involved in this TDM?
Government setup, I'm not sure. With Thyrocare, when I was checking with them, we wanted to just cross check our method which we have developed, multiplexed. So for one drug, they were charging 5,000 rupees. So if you are doing a full PK study at 0, 1, 2, 4, 6, 8, almost 6 time points, 6 5 is a 30,000 INR. So that's a huge amount for one drug. Yeah.
And about pharmacogenomics, which you mentioned, so which all setups again are doing, and is it commonly done?
Yeah, about pharmacogenomics, as of I know, which have last year also when I attended pharmacogenomic conference, even though pharmacogenomic conference happens in India, nobody talks about infectious disease related genes or that. So we are one of the labs in India who are doing pharmacogenomics based testing. We have developed a customized multiplex panel where we have done 42 plexes, 42 different genes. We do both for first line and second line anti-TB drugs. Second line is done by our postdoc, Dr. Priyanka. So I work on first line anti-TB drugs. Other than that, there are no commercial assays available. And if we talk about the pharmacogenomic panel, again, I don't support the companies or something. I'm just giving some names which I've come across. Indigene does for NAT2 and SLCO1B1. SLCO1B1 is important for rifampicin metabolism. Other than that, they don't have other genes which are needed, like especially for ethambutol-induced optic neuropathy. They don't have OPA1. They don't have any of the mitochondrial genes. So they don't have many of the genes for pyrazine needed. And second line, no genes.
And any
So
drug
yeah.
in which TDM is not useful for TB?
TDM is not useful, as I mentioned, for idiosyncratic reactions. For ethambutol toxicity, if we have around 40 cases right now for ethambutol-induced optic neuropathy, it's a collaboration project with the Vithala Institute. So in those patients, uh, there was no such other side effects which are caused due to high drug levels, and mostly whatever publications have gone through, none of them are mentioning high drug levels. Most of them are mentioning there was a mutation in mitochondria, especially the mutation which is commonly found in LHON, Leber's hereditary optic neuropathy. That particular 11778 mutation is found. Okay. Other than that, there are other reactions, like as already mentioned, for lactic acidosis in case of linezolid. There's one wonderful publication where they've explained entire case how they identified that particular gene mutation in those patients. So in these cases, TDM is not useful.
So thank you, Shruti, for that wonderful presentation. Uh,
Can I?
yeah, yes, please, sir.
Thank you, Dr. Pratibala and Dr. Shruti. On behalf of AMR Declaration Trust, we express our gratitude for both of you for the wonderful topic and discussion. But I'm also sorry that I joined very late. I was traveling out of country. I came back this morning. So it took time for me to finish my hospital rounds. I joined late and I missed most of your discussion. It's my loss, such an important topic. And being an infectious disease physician, I had to agree that most of the topic you discuss, the content of it, we are ignorant. Not just me, I think I would like to say a majority of the clinicians are ignorant. We know TDM exists, we know pharmacogenomic exists, but when it comes to TB, it is neglected. Yet, how many patients we prescribe ATT every day? But we follow the national program. As Shruti once mentioned, we continue ethambutol for the whole continuation phase. And we have seen plenty of cases of ethambutol-induced uh, toxicity. And nowadays, in my clinic note, I make it a point that I counsel on ATT side effect, including visual effects. And also, I write that, please have an ophthalmology opinion every 2 months if feasible. I know it's not a part of recommendation. I agree that. But considering the number of patients with at least mild optic neuritis with visual toxicity, we find it difficult for patients for the full continuation of ethambutol, especially we have Northeast patients. We prescribe ATT. We don't know where they follow up. Yes, of course, we do the notification, but we don't know many of them are followed up properly. And some of them later call with visual toxicity. So, what is the solution? But TDM is expensive. Very few government centers do it. Even for Apollo patients, most of them are affordable, but still not that affordable with TB. So, what is the solution for practicing clinicians in India? And we have got audience from across the world. So, what is your recommendation to the clinicians when we should do TDM and when should we do pharmacogenomics? For
Yeah.
both of you.
I'll answer this question in two parts. First thing, for ethambutol-induced optic neuropathy, it's not always ideal to call patients for ophthalmologic testing. Simple thing what we can do to them is just give them Ishihara chart at home, let them read. That's a very simple thing, and it won't cost them more than 100 or 200 rupees to buy that Ishihara chart. They can do assess their own thing, and when you feel there is some change, please consult ophthalmologist. Simple thing what we have told many of our patients. And I'll answer the second part: when to do TDM, when to do pharmacogenomic testing. Because my work completely focuses on pharmacogenomics. Still, I won't tell you do pharmacogenomics right away, because even now in India we have not reached that stage where doing targeted sequencing is very cheaper. With Minion earlier, with flow cell, which was costing less, and all fungal flow cells, it was easy. Not anymore. They have also come with high cost burden. So I would suggest doing TDM when the patient comes to you with an ADR is a must. Is a must. It's a non-negotiable thing. Then adjust the dose based on that. And for the treatment response rate, anyhow, they go only come twice during their visit for treatment response. So in the treatment response, again, in India, we're still lacking. We're not doing, first of all, the AST correctly. First line, all the drugs are not tested. First, go according how the program suggests. Test for the drugs if they are having now this concept on heteroresistance, where you should also look. Gene expert is missing a lot of heteroresistant cases. Get all those things tested by doing a sequencing, and then you should think about going for TDM. That's what I suggest, especially if the ADR is not affecting the livelihood of patient. I wouldn't suggest you for mild cases do a TDM. If he is not taking the treatment properly, he's not able to take the drug, he's having continuous nausea, vomiting, and he's having jaundice and all, then please go ahead with the tedium. And I particularly suggest basically for the second line anti-TB drugs. Pharmacogenomic testing is still not a standard of care in India. There are no panels available. We are coming up with a panel. Maybe it will take another 1.5 years for it to completely get validated across the Indian population. So even after that, pharmacogenomic testing, if it becomes a test, our goal is to make that. If it becomes a test which can cost you just 5 to 6,000 per test, get it done. Because your human genome doesn't change. If you test once, whole life, anytime he gets not only TB, NATU can also talk about other drugs which are metabolized in that under that particular enzyme. So it costs one time, get that done, 5 or 6,000 rupees, and patient is set. So I would recommend once pharmacogenomics becomes a norm, then as soon as the patient walks in, there should be a test which will tell, okay, he is a drug sensitive or drug resistant. With the same DNA, do pharmacogenomics, tell, okay, he is a fast metabolizer for this drug. Try considering this and recommend the patient. If you develop any of this ADR, come to us. We will change the drug dose.
So if the patient can afford the testing, for at least for INH, pharmacogenomics, do you recommend that?
Yes.
Because most of my patients can afford it.
Yes, absolutely. But do you have a test in line is a question again. Because there was a study by my guide, which was done in Cape Town, South Africa, and also they have validated it in Brazil. So they have found that the most of the tests which were available, they were missing out on one polymorphism which was specifically present in African population, which is 119G2A mutation. That was missed. And they actually called most of the patients who were fast metabolizers as slow metabolizers because they missed that one polymorphism. Before we do NAT2 genotyping in Indian population, we need to have data on Indian population, which is most common, which is less common. Yes, because it is always a combination which we take when we talk about NAT2. It is not one SMP. It has 50 star alleles. So when we talk about star alleles, we should again run a random forest model and identify which are the important star alleles for Indian population. That's after that, NAT2 is good to go.
Dr. Preeti?
Yeah. Any more questions in the chat box, Afrin?
Yes, ma'am. There is one question in the chat box. Dr. B.S. Lakshmi has asked a question. Is there any advantage of therapeutic drug monitoring to avoid or prevent multi-drug resistance in TB?
Yes, that's again a far-fetched question. There are systematic reviews which are mentioning on the emergence of drug resistance, which are correlated with the patients who had subtherapeutic levels. Uh, Yes, obviously, in a long run, it will prevent emergence of drug resistance because you are causing a selection pressure in those isolates. For example, if the patient is having 90 is to 5, 90 sensitive and 5 resistant isolate, the 90 sensitive are dead. You are enriching the environment for those 5 resistant TB bacilli to grow when there is no other organism, completely no other organism in the blood, where you are suppressing all other organism with the antibiotic. You are giving them almost like a growth media or a nutrient rich media for to survive. Definitely, it enhances multi drug resistance in TB. And but right now, doing reactive testing itself is a good approach to go ahead in India.
Yes, ma'am. Thank you, ma'am. And, no more questions noted, ma'am. Any other questions, ma'am?
No, I'm good this side. Mhm. So can we conclude if there are no more questions?
So before that, as
Yeah.
as a clinician, what will be your message to the practicing clinicians who prescribe ATT every day for several patients?
Uh, After you prescribe, it will be a good to have, give them a key indicators. This is what it's my personal view. Key indicators when they should seek the hospital visit again, what they should keep a check on, the basic looking at their sclera color changing, they can do when they get jaundice, they can easily say. And checking for Snellen's chart or Ishihara chart, they can easily do. Or they don't have to check the Snellen chart in a house. My own mother, she looks at the calendar and she tells, okay, I could read the first line, now I can't read the second line. So that's a basic thing what a patient can be aware of, and these kind of changes can be easily picked up. So you can just counsel the patient on what are the probable areas, as you already mentioned, sir, that you counsel the patient on areas, and ask them to seek care rather than stopping the drug. So that is one thing. Hope I answered the question.
Thank you.
Yeah, and they should remember that one size fits all was a old norm now. So there should be a personalized and tailored treatment approach for each patient.
Yeah, that's a very good point, Dr. Preeti. Actually, when we were reading Harrison back in 2012, we used to read evidence-based medicine, evidence-based medicine. Now it is precision dosing, precision medicine. So
What is
yeah.
as you know, the current RNDCPN guideline has come out. Does it mention about pharmacogenomics or TDM? Actively recommending it?
No, actually, we had
No.
a last year when I had a meeting with Dr. Somshekar in NTI Bangalore. So even they are looking for how to start TDM and all. If reference center is thinking to start on TDM, so we have to forget all the PHCs and even the small hospitals starting one. So it's not currently in the recommendation. So this particular question, even I posed to the director of NTA also. So why are we not stopping at Hambutal? So the answer is simple: isoniazid monoresistance. So yeah, currently there is
So what you
no
suggest,
guideline
see,
on
at
such.
least those people can afford, we can do the
Hmm.
pharmacogenomics for the INH resistance?
Hmm. That too.
Okay, right. So what will be your recommendation if I don't want to continue Kethambutol in the maintenance phase? Am I allowed to do that because RNDCP
Huh.
recommends?
We are not
Suppose,
allowed to do that going out of the program. I'm not sure about the legalities of how the patient can be treated out of the program, because I have never practiced outside in a private setup. I've always worked in government, so I'm not sure about the legal part of it. Otherwise, if we can get away with ethambutol, if there are no legal constraints, I would recommend get away with ethambutol. Get first line testing done by sequencing for all the 4 drugs, because in sequencing you even get the resistance for isoniazid, all the first line and second line anti-TB drugs, along with you can get for heteroresistance part of it. Even if there is any resistant subpopulation of isoniazid, you get to know about that with whole genome sequencing, or even with the targeted sequencing if the amplicon coverage is good. Obviously, amplicon coverage will be good with targeted. So I think that will be a good approach to go.
so your recommendation, if the NAT is positive, then of course we can look for the resistance. So look for the resistance, at least for the first line drugs, and if possible, do at least for INH pharmacogenomics.
Yes. At least then we will be at least in par with the global population who are doing.
Right.
So, sir, we'll wind up the session, or you have any other questions, sir?
So I don't have audience. Any more questions?
No, sir. 1 minute, sir. There's another question, I guess. No more questions, sir.
Right. Thank you, Dr. Shruti and Dr. Pritibala. Thanks a lot for a wonderful discussion for both of you, and a very important topic. You should do this session in all the platforms, because we all claim that we know about tuberculosis. But if you discuss the depth of tuberculosis treatment, and there's a lot of ignorance among all clinicians, among all prescribers, and you need to do a lot of sessions to educate clinicians.
Definitely, sir. It's actually encouragement from stalwarts like you, which will keep us going and doing more work on TB treatment and the pharmacogenomics. Thank you so much for the opportunity. And for Dr. Preeti, because I had discussed this topic with her once when we were working together. So yeah, she remembers. She was like, "Can you talk on this?" Yeah.
Thank you. Afreen?
Yes,
Dr.
sir.
Pritibala?
Yeah. Thank you everyone for joining, and I hope like this topic inspires young minds to explore new opportunities in TB, so that we can end TB. Try to at least end TB from our side. Yeah. Thank you. Thank you, everyone.
Thank you, ma'am. Thank you, sir. Thank you for moderating
sir,
throughout
for
the
this
session, ma'am.
opportunity.
Thank you. Thank you so much, ma'am. So we'll end the session today. We'd also like to extend our sincere gratitude for all of the attendees and the speakers, moderator. Thank you so much. And also our sponsors, Viatris and Pfizer, for their continued support. Thank you, sir. We'll end up the session. Thank you.
Thank you all, and happy Diwali, everyone.
Happy Diwali.
Thank you, ma'am. Happy Diwali.